awareness and focus on choosing carefully, delivering precisely, and most importantly, attend carefully. The patient needs to be attended before, during, and after surgery. That's when complications occur. Now, indications of tracheostomy. Now, indications of tracheostomy are quite simple. When there is any obstruction to the airway, which can present as acutely, or there is progressive obstruction of the airway, this is one area. The other area is when we are needing to support the airway, that we often see that when we support patients in critical care. So there are a handful of indications, but most important thing here for one to remember that why are we doing this? How long is the tracheostomy needed for? And is this the right choice? Now, what I put on here is a very recent paper which looked at this, and two of the questions that we very often face: tracheostomy versus prolonged endotracheal intubation. A lot of our trainees often face this from the critical care to say, this patient needs a tracheostomy, can you please do it? But the evidence does not support it to say that there is any change in the outcome of the patient in terms of complications to reduce to do the tracheostomy early or late. So this is the tracheostomy, the number 3 evidence. In the number 4 evidence on this paper is another issue that we often face. Does the patient have a percutaneous tracheostomy, or does this patient have a surgical tracheostomy? If you look at it carefully, and they looked at a very large group, you'll see that the surgical tracheostomy and percutaneous tracheostomy, there's only difference is percutaneous tracheostomy has less complications of skin infections, stomal infection afterwards. There is no contraindications for tracheostomy as such, and it is quite obvious because death is not an option. So you'll have to find a way to allow the patient to breathe. But these factors that you see here are important factors to keep in mind. And of this, what we often see is the short, thick neck that we often find, and the neck that does not move very well. All the other factors are there too to take note of. If we don't take note of this and the patient is on the operating table, that's when we run into trouble. Now, Incision Design, and this is also an important paper for those interested to read this, and it's a large paper looking at different aspects of this. This is very important to remember, that depending on how long do you want the tracheostomy to be there. For a temporary tracheostomy, it is very important that we always follow the cartilage sparing approach. Do not take too much cartilage away, and if it is at all possible, or where possible, maintain the geometric integrity of the trachea. So whether a vertical incision or a transverse incision is designed, is very important to work out that is going to allow what we are looking for. A tracheostomy to secure the tracheal lumen airway for 72 hours to a week, or temporary tracheostomy. In case of a tracheostomy that is going to be there for a long time, or actually permanent tracheostomy, removing parts of the trachea may be necessary. Otherwise, you would not always be able to get a good stoma, and then stitching it up to the skin. You often come across this conversation, or sometimes also debate whether one should use a Bjork flap. We don't routinely use Bjork flap, but if you look at the evidence and the literature, there are many people who use it. So I'm not going to go into a debate here about whether we should use Bjork flap or not. But if someone is using it, one should be aware of the problem that you might face with the flap present distally, which might actually cause obstruction by moving inside in the tracheal lumen. Percutaneous dilational tracheostomy is probably the most frequently used tracheostomy method, because over the last 20 years, tracheostomy done at critical care has improved astronomically because of the skill they have developed. And this is a very safe way to do tracheostomy. And especially in the time of COVID, you would have seen the number of this has gone up. Now in United Kingdom, in England and Wales, annually we do 15,000 tracheostomy compared to 100,000 tracheostomy done in the United States of America. So you can see that vast majority of those tracheostomies are done by this procedure. Complications of tracheostomy. It's important to understand how they appear. There are immediate complications of tracheostomy as on the table, intraoperative complications, then early and the late complications. Of the whole list of that, the most important thing that one should be very careful of, that tracheostomy does not cause major hemorrhage. It does not go into a false passage. And the tracheostomy tube doesn't get displaced soon after it's been put into place. The serious complications of tracheostomy is often when the tracheostomy tube is gone into the false passage, it has gone past the trachea into the esophagus, or it has got blocked. Another issue with perioperative care and not been looked at. So it's important that we look at that in a strategic and in a systematic way so we know what we are expecting. And going back to my second slide, it's important here that every patient who has airway surgery is attended very, very carefully and constantly. Now, I wanted to bring in this publication of 2015 of SHINE document on improving multidisciplinary tracheostomy care. This is also related to the global tracheostomy collaborative efforts. This is from England. And what I wanted to highlight here is, if you look at this dotted line, you see more than temporary harm, and you see how many patients are getting more than temporary harm. Another thing to take into consideration here is death. Death happens in patients with tracheostomy as a result of tracheostomy. Now, in these two publications, you'll see that these publications that looked at nearly 800 patients retrospectively, and they have found 1.4% of the tracheostomy were related to the mortality of the patient, which is a small number, but is a hugely significant number. And on this side, you'll see that what they've looked at is the cause of death. They looked at over 25 million deaths over 10 years, and they have found 623 tracheostomy-related deaths. And interestingly, they found that this happens more often at the wrong time. I wouldn't say wrong time, in the weekends and late hours of the day. And tracheostomy-related complications were significant number in individuals of different demographic groups. They also found that complications of tracheostomy happened less in intellectually high status people, which is interesting because they are very aware of what might go wrong maybe. Now, I would like those interested in understanding it better to actually read this paper, which has got a very, very recent and a large study showing the different aspects of tracheostomy and management. And the websites here that has got UK National Tracheostomy Safety Project, which most of us should be aware of. Tracheal stenosis is a rare but potentially life-threatening problem. Prolonged intubation, tracheotomy, tracheostomy, granulomatosis with polyangiitis, neoplasia are some of the causes. Significant symptoms may not manifest until 50% of the tracheal lumen is occluded. So this is an important point to know. And there may be many people out there with tracheal stenosis, but there is no symptoms unless they develop a chest infection, and then they present in the ward, in the medical ward, and then you find them. If that patient is lucky enough to get an endoscopy or a bronchoscopy, you might find that, or on a CT scan. Not every tracheal stenosis needs surgical intervention, and that's an important point too. When do you intervene? Now, all the evidence points at a teamwork. When you're doing tracheal stenosis, surgery for tracheal stenosis, teamwork is the most important thing that brings you success. Patients-focused outcome is often ignored in many of the practices. One of that is dyspnea of shortness of breath. The outcome that patient is looking for is not always the outcome the doctors are looking for. Laryngotracheal resection and tracheal resection and reconstructions. So in this here, I am just concentrating on tracheal reconstruction and resection and reconstructions. It's important to take into account that up to 3 centimeter, which is 4 to 6 rings, may be resected, and anastomos primarily. If you want to do anything more than that, it is necessary to do other procedures where you're able to release do suprahyoid and infrahyoid release to allow the larynx to come down, also to do other procedures, thoracic procedures to pull the trachea up. This is for high tracheal stenosis management. Now, complications of tracheal resections surgery are grouped under 2 headings: anastomotic complications and non-anastomotic complications. Now, anastomotic complications, the most important anastomotic complications, which may happen up to 1% of reported cases, is anastomotic separation. This is the most important complications to be aware of. Sorry, am I running out of time?
It's 2 minutes.
Okay. Other complications are listed out here. So pay careful attention to these. These are patients-related factors that one should know. And of the whole of the list, the most important are, if you are doing reoperation, patients with diabetes, patients who has laryngotracheal stenosis under the age of 17 years, or anyone who is needing tracheostomy before tracheal resection surgery at a high risk of complications. So to come to the end, what I would suggest everyone to contemplate is, before you do any airway surgery, please keep in mind, do no harm, choose carefully, deliver precisely, and attend constantly. You need to understand what you need to avoid and focus on what is the best option for the patient. Thanks for your patience. Thank you.
That's fantastic. Sam, you got still a minute. Maybe I'll ask some questions. What's your preferable options? Do you prefer percutaneous tracheostomy or surgical tracheostomy?
Well, it entirely depends on what is the context. If this is a patient who is in critical care, I think that this percutaneous tracheostomy is my preferred option if this can be delivered. There are situations when the neck is too thick or there are vessels in the way. Ultrasound is showing that this is not a reasonable anatomy for critical care consultants to do. Then we may do surgical tracheostomy. But I think in the critical care situation, that's the better option. If you are going to be doing this before, as a part of your surgery, the surgical tracheostomy, emergency tracheostomy, as you know, is almost always surgical tracheostomy.
That's great. That's a question from the chat. That's great. Thank you very much, Sam. You're spot on time. I think we are coming to the last session. That's going
Thank you.
Thyroid and parathyroid complications, and it's going to be chaired by Dave